Welcome to Season 4 of Inflammation Nation. My name is Tara Regan. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. I'm delighted to welcome Professor Oran Kennedy to this series of our podcast to discuss posttraumatic osteoarthritis. Oran is a lecturer in the Department of Anatomy and Regenerative Medicine at RCSI, where he is part of the Tissue Engineering Research Group cluster, and he's an expert in the biomechanical and mechanobiological properties of musculoskeletal tissues. So Oran, thank you very much for joining us today. You're very welcome, and we really appreciate you coming into the studio to chat to us about this topic. So I suppose just to kick things off, Oran, maybe you could just tell me a little bit about your background and why you became interested in science in the first place. Was it something, from a very young age?
Yeah, sure. Thanks for having me, first of all, and thanks for managing that introduction, which is a bit of a mouthful with some of those technical terms. Yeah, my background is unusual, I suppose, and interested in science. I mean, it was a bit of a family affair for me that my dad was a scientist and stuff, so that kind of stuff was always around us, and I guess it's fairly typical. I was just always interested in trying to fix things. I never actually did fix many things, but just getting involved in technical stuff like that around the place and in school was always of interest to me. So that's how I got into that, and I got into engineering then. In college, I always think it's a great subject if you're anyway inclined in technical stuff, because I find it really interesting, and it gives you lots of options with what to do. It gives you a broad spread of choices, I suppose, for career pathways and stuff. And some of them are kind of unusual, which would be the case for me, because I went into, from an engineering point of view, dealing with materials and metals and components and things like that. I got into medical devices and orthopedics in particular. So I worked for a time on the components that go into a hip replacement. So it's a metal piece that will ultimately replace a hip joint. And that then took me into the world of musculoskeletal medicine and joints and diseases and all of that. And joint replacements and, artificial hips and knees are still really important, important. Yeah. But I think about 10, 15 years ago, people started to realize that they work really, really well, but they sort of have a finite lifespan, so that they only ever last, let's just say 15 to 20 years. Okay. And then if you think of, people are starting to get them younger, and people are starting to live longer. So it just seems like there's, coming down the tracks, we need other options. So even though I was sort of an engineer to start with, I started to become, and people like me started to think about biology more, but bring a kind of a mechanical or an engineering perspective to it. So we try and kind of regrow things in the lab now, and to replace or maybe to improve, cartilage that is damaged. Okay. And bring a biological aspect and regrow things rather than just replace them with synthetic materials. So that's that's what's taken me to where I am now. And now I have, starting off from mechanical engineering, I have a research lab in an anatomy department in a medical school. So it's a bit of a unusual route, to say the least. But it's great.
It sounds fascinating, though.
It's great, yeah. I love it. Yeah, it's great.
Fantastic. Okay, so we're here to talk about posttraumatic osteoarthritis. Yeah. And I suppose we're very familiar with hearing about osteoarthritis in Arthritis Ireland. And unfortunately, it's a very prevalent condition. And it seems that the incidence is also on the rise. And a lot of that, I suppose, is, related to our lifestyles and dietary issues as well. But this is different, I suppose. And we're here to talk about this as a subtype of osteoarthritis. So maybe you can tell me a little bit about what's different and how, in what way it's different to osteoarthritis. Sure, exactly, yeah. So really, the ultimate situation that arises is similar in that it's arthritis, which causes pain. And, if you looked at an x-ray, you would see similar things. But the big difference here is how it starts and when it starts, I suppose. So PTOA, or post-traumatic osteoarthritis, is a subtype of arthritis, and it's all related to an incident. Okay. Or an injury. Yeah. Okay, so that's an easy-ish example to think about, is a knee injury, because lots of people have twisted their knee or hurt their leg in that way. So if you have let's say you have a fracture, a bad injury, and it involves the joint. And what I mean by that is, if you had a fracture, let's say in the middle of your shin, and it's not near your ankle or it's not near your knee, that probably wouldn't cause a problem. But if you had one, let's say at the top of your shin, and a crack kind of went into your knee joint and disrupted the nice smooth cartilage there, that fracture might heal well enough. It probably would, actually. Most fractures heal quite well. But if the joint itself had been damaged in that situation, then there's an increased risk of that joint subsequently kind of degenerating and becoming diseased, Okay. So that's a fracture that actually goes in and involves the joint
is one example of something that could cause PTOA.
Okay.
Another one that's probably more common is damage or injury to soft tissues around the joint. So as opposed to that first example, which was fracture in hard bone, all the things around your knee joint that help it work well are your ligaments and all of that, all of those soft tissues, and meniscus, which is like a shock absorber that's in there. Those can get damaged, and they often do get damaged, often in sports, often in young people. And if they do get damaged, it's normally if they get quite badly damaged. So you might have heard of an ACL, anterior cruciate ligament tear or rupture, or a torn meniscus, or things like that. So if it's kind of relatively bad injury like that, then you also have an increased risk, unfortunately, of developing PTOA. So it's the starting cause that makes this different. But that can be actually useful because if you're trying to detect something early, in this case, you know what started the process, as opposed to in some situations where the first thing you know about it is when it's really quite sore and quite bad later on. So
okay, yeah, because I suppose the thing with osteoarthritis is that it's quite subtle and gradual usually.
Yeah.
So a lot of people don't realise.
Disease and most of us, I think it's just human to sort of put it off until you really need to get it looked at, and so that inevitably means that it's sort of advanced or progressed by the time you start thinking about it or having it looked at.
Okay, so there's an opportunity to address this earlier on because you know the starting point.
Exactly.
So how would a person be typically diagnosed with PTOA, post-traumatic osteoarthritis? Are the symptoms different?
So it goes back to the cause of it really. So, but it's an interesting question because once it's developed, the actual end result is quite similar to regular arthritis, I suppose. But just for example, I'm always keen to get people thinking and talking about this, which is why it's great to come on here today and talk to you. If you think about the case that people would know more about, so this is your sort of regular age-related arthritis, and if somebody has a really sore knee and they go and get it looked at, and it's really quite bad and quite damaged, in those cases, the conservative approach, exercise, is always best. But sometimes it can be hard, and sometimes people will say, if it's really bad, you shouldn't. If it's gone beyond a certain point, you shouldn't kind of go too hard on it. Yeah. Whereas if you go back in the situation of PTOA and you have one of these nasty injuries early on, I think that gives us an opportunity to think about it and act then.
Okay.
For example, the way those injuries are handled typically. So if you have somebody that has a torn ACL, let's say, the treatment at the time and the subsequent increasingly likely development of PTOA are sort of treated separately. So if you have this injury, the injury is fixed at the time, and they fix them really well, by the way, as well. So you might have heard of people going to get their ACL injury reconstructed, is the word used. So they get fixed, and it's sort of mechanically fixed. This is why I love it. It's like a mechanical component again, and they fix it in a really interesting way, by the way. Maybe that's for another day. So they fix it up really well.
Yeah.
Because these things are often linked to sports, they say, you're back to sports or you're back to lifestyle can be within a couple of months, and they do a really good job of it.
Okay.
And then it's sort of a side note, by the way, but you might develop something here
further down the line,
and then come back to me then, and we'll see what happens. And if that does happen, then it's sort of treated as just normal, a normal case of age-related arthritis.
Okay, so it could be sort of almost festering. In the interim.
Yeah.
So somebody maybe has this injury, they have surgery, the surgery is successful, they're keen to get back to playing whatever sport it was that they were involved in. Is there anything they can do then to prevent the progression in the interim? Is there something that can be...
Such a good question, because this is some of the work that we're doing in our labs at the minute, actually. So that's an active area of research for me and lots of people like me. At the moment, there's not really. And I think the main thing is always going to be just maintaining the consideration for exercise and maintaining joint health in the normal way, But it is good to do that because, as I said, sometimes if you leave it too long, some people say, you shouldn't go too hard on an actively degenerating joint. But if you're in that situation of PTOA where you've had this injury, but it hasn't happened yet, just keeping up good joint health and activity and exercise is really important. But we're interested in our labs, it's at a very early stage in just trying to understand what exactly is going on. And as you said, it's a good word, like something that's probably festering, low-lying in the background. And we often use this when we're trying to, convince people to give us, research funding to do this.
Yes.
That I always use the term, there's a window of opportunity.
Absolutely.
There's a window of opportunity to sort of link the current. And by the way, I'm always conscious to say really high standard of care, let's say, for this injury. And then if it does then develop later on, it's always really well looked after. But I think there's a sort of a different way of looking at these things, at a window of opportunity to link those two things, and maybe down the line we can develop something that can be actually used early on to prevent the second stage from happening.
So it essentially at the moment, what happens is you have your injury and then you go back to your normal life and hopefully you get back into your sport, and then later on you may develop osteoarthritis, but they're treated in isolation. They're not treated as connected incidents.
And again, it's not a criticism of anybody or anything.
Sure.
That is, and they're treated really well, but they tend to be treated as separate things. It's kind of, if that arises, we'll deal with it then. And it's not really thought of as the same thing, even though it is kind of linked, because if you think of the situation that we're discussing here, this could be somebody, let's say in their mid-20s, who's playing sports at the weekend. They have this injury, 24 years old. If you look at the statistics, a bad enough injury like that, which they'll recover from in a few months, around, let's say, 60% chance of sort of a degeneration process happening and presenting itself in 10 to 15 years. So that's sort of, late 30s, 40s. And that'd be just considered as a person with OA then.
Yeah.
But it is a totally different thing. Like that person, apart from that injury, most likely would not have had age-related OA at the age of 40. Do you see? So there's something different about it, even though it presents itself in a similar way.
Yeah. And I suppose one of the things that strikes me about that then as well is that obviously if people are developing this quite young, they may have to live with this for a very long time. So they will develop OA quite early and then they'll have to live with OA for a long time. And that presents issues as well in terms of management and outcomes, I suppose.
100%, 100%. Okay. And I think, taking the best parts of each of these stories, so always maintaining kind of good joint health and activity and all of that is going to be good, and hopefully we could, we or someone like us can come up with something in the meantime to help. It's always aspirational, but probably unlikely that you're going to come up with a silver bullet to absolutely fix this or stop this from happening. But if we could chip away and learn more, and just improve the situation for people like this, I think it'll be good,
Okay.
For development.
So in terms of the research at the moment, are you actively examining people who've had, for example, an ACL injury or, for example, maybe, a car accident where, there's been a trauma or a break or something like that? Is that the work that's going at the moment?
Yeah, it is, yeah. So we have strong links with some of the hospitals around Dublin. And Kappa Hospital, for example, we have a research program up there. And just for example, you might be surprised at this, but in some of those procedures, be it the let's say the ACL repair, or be it later on if somebody needs a joint replacement, we can actually take some of the tissues that are removed during those procedures and study them real quick, just to see what's going on and to see how the cells and tissues are behaving at that time, and that then can feed into ways that we can develop medicines, let's say, to stop, if there's something bad happening in the cell tissues. When I say bad, I just mean, it's creating an enzyme, let's say, that's breaking down the nice smooth surface, which is part of the osteoarthritis process. Maybe you can come up with something to block it or stop it or, stop that from happening. So that's one of the things that we do as we, and it's sort of nice as well. We involve patients in this kind of work in the research, and we use that as a way to sort of, bring this work forward.
Okay. And typically with osteoarthritis, we talk about non-inflammatory arthritis, and then we talk about inflammatory arthritis when we talk about RA and PSA and other forms of arthritis. So I'm just wondering then, is there a difference then in the presentation with PTOA? Is there an inflammatory element to it, or is that something that's under investigation?
It's a great question, Tara. I'm glad you asked it. Yeah, so I always find it interesting that OA was typically always called the non-inflammatory arthritis, and that was in comparison to rheumatoid arthritis, which is highly inflammatory. It's an inflammatory autoimmune disease. Yeah, so OA was always thought of as non-inflammatory, but now if you think of that difference between sort of regular age-related OA and PTOA that we're talking about, there is an inflammatory component at the start, at the very least. So as in, if you have that terrible knee injury and you tear your ACL, then your knee joint would be very swollen for sure, and it would be swollen for a while. Now it would resolve within days or weeks, let's say, but we think now that there's a sort of an underlying unresolved inflammatory component as one potential reason, or one potential sort of way that injury can sort of drive or feed into the degeneration of the joint over quite a long period of time after that. So that would be, so when I say unresolved inflammation, it just means that something somewhere in there is just not quite right, even though your surgeon might have fixed it really, really well normally, and it mechanically works quite well as a smooth moving joint and all that, and you can go back and play your sports and all that. But somewhere in there, something isn't quite right, and it's just sort of, as you said, festering away in the background, And we think that that's going on, and we think that it's something that we can maybe sort of target or give a medicine for or whatever to try and prevent the whole process from continuing the way it is.
Okay. I'd say there's a lot of interesting work going on there in that.
There is. It's great.
Space.
Yeah.
Excellent. I'm just thinking here, there's probably going to be loads of people who listen to this interview and they may not be aware of this, and they're still active and they might have had an injury. So are there any promising treatments or therapies, that are sort of in progress at the moment, or is there anything exciting in that space?
Yeah, so I think a lot of the work on new treatments is still very early stage. So we're still in the labs with this kind of stuff. But even the fact that we're sort of having these conversations now and that people are aware that this is, it is, and it's easy to see why it's considered as a sort of a similar thing. So if we go back to the statistics for a second, I was mentioning earlier that, OA is very, very common. And now we kind of think about PTOA as a subcategory. It's about 12% of, if you went into look at any population in a country or in a hospital, whatever, and you have this number of OA cases, about 10 or 12% of that is probably going to be PTOA related. So we're thinking about it differently now, and we're trying to understand what's happening in the early stages, because this start point is sort of known now and recognized. It gives you a window of opportunity, as I like to call it, to intervene and do something about it. So we're still really learning what is happening in those early stages, and we're getting a handle on how we can stop them or manipulate them or target them. So it's all very early stages. But inflammation is one thing that I mentioned that we think is involved. And I think more and more people are learning more about our immune system and the inflammatory processes now after COVID and everything. But it's an amazingly kind of complicated but rich sort of topic, and there's loads of nuances to it. So it'll probably take us a while to figure this out. But that's one example of something that we're trying to target. And another thing that we've realized in recent years in this topic, in PTOA, is that most of the time people think about and talk about and consider the cartilage in your joint as being the main and only thing to think about. And it makes sense, because it's an amazing material from an engineering point of view, by the way. And by the way, in labs we can engineer and develop and make synthetically nothing like cartilage. It's an amazing tissue and material. The things that we can develop with all the best science and technology in the world comes nowhere close.
Okay, so we're not there with that.
No, but it's an amazingly difficult thing. But I always like to look at the positive sides. The fact that we make it ourselves, it's fantastic. It's this 1 or 2 millimeter thick tissue that's just fabulous. From an engineering perspective. But anyway, everybody tends to focus on that, and understandably, because it allows all that pain-free movement in all of our joints. But we think now that, especially in a joint injury, there's lots of other things in your joints. The actual kind of bone underneath it, it's called subchondral. That just means under cartilage. The bone directly underneath gets quite badly damaged in an injury like an ACL injury. Okay. And you can actually see it if you go, you would go and get a scan of an injured knee joint, and you could see in that scan that, you have let's say a torn ligament or something. But in 80% of those cases, you also have quite a lot of damage in the surrounding bone tissue. And that's not something people ever thought much about before. And that's another thing that we're interested in learning more about as a potential kind of target, or it could be that there's something happening in there that we need to think about, or could potentially do something about, or target as a way of stopping the development of OA.
Okay. So when somebody has, for example, an ACL injury and they're getting all their tests and diagnosis and, scans. So basically we could do more investigation during that process or during that period then to assess if there's a potential for PTOA further down the line.
Yeah, exactly. Okay?
There's a big job, I suppose, in terms of education and bringing people along on this journey.
100%.
I'm even thinking about, things like sporting organisations probably need to be more aware of this, really. Because I think, younger people are playing more and more sport and high intensity sport. Are there any specific, sports in particular that are where you're more at risk?
Well, I think, PTOA can affect any joint really. Knee and ankle tend to be the ones. Knee is the kind of easiest example to use, I suppose. And so for knee injuries, contact sports, sports with a lot of twisting and turning. Twisting, the knee is a great joint, is a fantastic joint with all those degrees of freedom, but it leaves it a bit vulnerable to injury. Sure. So twisting, turning, cutting, as they would say in America, is then if you're looking to go one direction, then you quickly change to another direction. Okay. Those are all quite hard on your knees. And so So basketball and soccer and GAA and rugby, with tackles especially, are all sports where you can, unfortunately you see you do see a lot of ACL injuries happening. Yeah.
Okay.
Yeah, so
and
everybody
is there much are there much efforts to prevent that? In terms of warm ups and I presume that's something.
So great question. Yeah, it's a great question. So yes, like specific knee joint movements that are protective for your knee joint are done in some places. And by the way, as well, between males and females, female knee is a little more susceptible to ACL injuries, unfortunately. So I've heard of working with some of my physio colleagues that work with women's sports team, and they do specific exercises for ACL injury prevention, because it's just really important, because these injuries they're common, but the treatments for them are really good and all that. But it's they're not nice either. You want to avoid them as much as you can.
Prevention is better than cure.
Yeah, 100%. Yeah, 100%.
Okay. One of the things I'm just conscious of with this is obviously we don't want to deter people from partaking in exercise, because we hear so much about being sedentary and how that in itself brings its own risks, and in particular osteoarthritis, which is sort of ironic in a way.
Counterintuitive,
So it's more, I suppose, about knowing the risks and being aware of them. So is there anything we can do ourselves to prevent, PTOA? Are there exercises that we can undertake? I know obviously during the warm-up and, with participant sports, but say, for example, if somebody's exercising by themselves, are there should they be considering this as well?
Yeah, I suppose, I think good joint health, there's only so much you can do, I suppose. These kind of injuries that we're talking about, thankfully they're not that common, you know what I mean? They are something that occur, but most people will go through their sports and their activities without ever having them, which is great.
Yeah.
But I think I was just being conscious of joint health, and like you said, warm-ups, and maybe sort of specific warm-ups, rather than just if you're in some of these sort of higher risk sports, rather than just a general warm-up, maybe loosening up and giving specific isolating exercises for knee joint and ankle joint. Sometimes it is easy to forget if you just want to warm up and get going. But but maybe sort of just looking after those joints, and always being careful with them and conscious of them is a good idea.
Okay. Just to go back to a little bit more about the research work that you're doing, what challenges do you face in that space? I'm sure there are plenty of challenges, but maybe I'm just interested.
That's another great question. The challenges of this are, so like OA and bad joints have been around for since our ancestors decided to go bipedal. The joints are always under a lot of pressure, and so people have been looking at this for a long time. And I think one of the difficulties with it is that these tissues, they're so different. Your joint tissues, if you think about it, it's kind of interesting. They're so different than most of the other organs in your body. And what I mean is, if you think of, I'm not sure if people would know, if you look at a piece of cartilage, it's really tough. It's really, really tough, and it's white. So it doesn't have any blood supply. It's white. If you think about it, if you think about muscles, if you think about most of the things, it doesn't have any blood.
So it's kind of like an isolatory.
Yeah, it is.
Thing.
Yeah,
okay.
And of course, all of our organs being used all the time, and they're being regenerated and reinvigorated the whole time. And that's all because they get nutrients and oxygen from the blood. So cartilage, it has a big job to do. It maintains all of our weight all the time. Like any movements of any joint, we think about knees and hips all the time, but fingers, neck, everything, it's all dependent on a smooth, like lubricating piece of cartilage somewhere. And it doesn't have any blood at all. And blood is what helps everything to heal.
Okay.
So it's missing. That's a massive challenge with it.
Because once it's damaged, it can't repair itself.
Well, exactly. Anything else, if you cut your skin, it bleeds a little bit. You get a good blood supply in there, and it heals itself. Almost miraculously. And same anywhere else. Other organs internally. Your liver can regenerate itself, almost a massive part of itself fully, massive regenerative potential. Cartilage has basically none of that, no blood. And the other thing with most of our musculoskeletal tissues, so bone and cartilage, for example, if you think of other organs, your eye, your heart, your liver, it's basically all cells. It's 90% cells with a little bit of stuff keeping it together, some kind of fibery bits and pieces. So it's all cellular.
Okay.
And then for bone and cartilage and the poor musculoskeletal system, it's almost always the other way around. So in cartilage, because it's such a mechanical thing, we call it the extracellular matrix. The bits that keep it together are the majority, and the cells are actually quite sparsely populated through it. Do you see what I mean?
So that's why it can't regenerate itself.
Yeah. So if you think about it, there's way more stuff and way fewer cells in your bones and your cartilage, as opposed to basically any other organ in your body. Most other things are all cell and a little bit of other stuff.
Yes.
And bone and cartilage is the other way around. It's all other stuff because they need to take so much weight. You need stuff around. So in your bones, that's mineral. Mm-hmm. And in cartilage, it's other stuff that allows that sort of lubricating movement.
Okay.
But there's very few cells and they don't get much blood. So that's the biggest challenge, is what I was getting to.
Okay.
Yeah.
So basically, it's much harder to develop something to overcome those problems.
Exactly.
Okay.
Yeah. That was a much easier way of saying it. Yeah.
We got there in the end. So I suppose one of the things I'm wondering about as well is that, so younger people are probably more likely to develop PTOA than primary osteoarthritis. So they're going to have to live longer with this condition.
Yeah.
So in terms of self-management, that's that's the cornerstone of what we do in Arthritis Ireland. You know, we teach a lot of, we talk a lot about, you know, self-management in terms of learning the skills and getting the skills to live with your condition well. To learn how to manage it. So diet, lifestyle. Yeah. Is that applicable in this case as well? Is there, you know, I mean, because I feel like your symptoms are going to be the same essentially. Yeah. So for example, would weight management be a consideration in there? Diet, keeping mobile? Yeah.
I think without wanting to give sort of clinical advice on this, I think two of those things definitely would be. I think weight is always an important consideration for joints. Yeah. And going back, at the risk of repeating myself, going back to the activity and maybe joint specific activity is always going to be really important, you know. And again, I think it is worth mentioning because let's say you had this knee injury when you were 20, you know, it might be easy to sort of, well, that's, you know, heal now because it normally will heal quite well and you'll get looked after really well. But in that interim period, you know, you could just sort of do your warm-ups the way you would normally do them or whatever, but it might help to do some
strengthening
exactly. Strengthening movements and specific, and just always remember that that happened, that joint might need a little bit of extra TLC and care and attention, you know.
Okay. One thing I'm wondering about as well is with PTOA. So, for example, if you undergo knee surgery further down the line or joint replacement surgery, are your outcomes the same with PTOA as they are with primary OA? Or is there a difference?
I think they are the same, really. You know, I think once in this scenario, once it's developed into sort of a degenerated, knee, let's say, knee joint, I think from the kind of, you know, from a surgeon side, it looks the same as your, you know, other more broad age-related OA, let's say. Again, the difference is it might be in a younger person. That might be the main difference. But I think once it gets to that sort of stage, I think it's treated in a similar way.
Okay. And currently when somebody goes for surgery, is there usually any, like, would they investigate previous traumas? Is that part of the assessment, or is that something that we need to probably capture?
I think it's another interesting point because the two situations are sort of dealt with separately and in isolation. Yeah. I think, you know, what happened 15 years ago isn't that relevant, really. You know, I mean, it might be noted down and it might come up in conversation because you're quite young to have this, you know, maybe. Sure. But I think they are once it's gotten to that stage, it doesn't really matter what happens. You know, from the point of view of how are we going to fix this? I don't think it will come up too much what the cause was if it was 10 or 15 years ago. You know, so but I just think it's important and it's good and it's useful to have these conversations and maybe link those two things a bit more. You know.
Well, I presume from a research perspective, it would be really helpful to know how many people would have had a trauma or an injury when they go on for maybe replacement further down the line, so that we can kind of piece the two together. And
well, exactly. Yeah. From my point of view, it's you know, this what happens early on is really interesting and it helps us to study it. And I suppose just in that scenario, if you're kind of, let's say 20 years down the line and things have just, you know, degenerated a little bit, it's kind of a bit of a moot point, you know, so in terms of how to deal with it. But
I guess a lot of people probably don't even put the two together, you know.
Yeah, I mean, I guess, you know, in those situations, if somebody's gotten to that stage and they just really need something done about it, it's kind of
that's the priority.
That's the priority, and the other stuff seems like a kind of a unfortunate distant memory, you know.
Which is understandable.
Of course, yeah.
Okay, thank you, Oran, so much for all of your insights. That was really fascinating, and we really appreciate you taking the time to come in and talk to us today.
Thanks. It was great to be here, and thanks for having me.
Thank you. That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or as they always say, wherever you get your podcasts. For further information about arthritis, you can visit our website, arthritisireland.ie, or contact our helpline on 0818 252 846. See you next time. Inflammation Nation is supported by Pfizer and AbbVie.